Adhikari.
We are running out of time. Everybody is, I think, they're quite hungry. And I am dividing this into two parts. Just before lunch, what's the time for lunch? It's 1 o'clock or 12:30? It's already there. So I'm dividing this into two parts. One is, I put some questions on ethical issues in clinical practice. This is copied one. Okay? And I'm also not sure that the level of the audience, but as I hope there are some students, some teachers, some researchers, so it's a varied group. So it's quite difficult to concentrate into a single agenda like that. But as a teacher, my presentation is more like a classroom presentation. It's not mine, okay? Because it's a learning part.
Yes.
That is one. Number two is that going to previous presentation, I like to tell a few things for your information or to share with that. Who is the real consumer in health? Is a very difficult question. Because a patient has no right or knowledge or say professionally to ask a doctor, I need ultrasound, I need this drug, I need that drug. So if you say consumer sovereignty, if I go to supermarket, I have got all the right whether I buy a coat or jacket or is it red or black. But in health service, there is no choice. So doctors are the consumer in a large part. For example, even in practice, okay, I write one ultrasound. I don't only write ultrasound, but I also say, please go to that one.
That one.
Okay, you see, but what is happening? The patient is being fooled in two ways. Number one, there is no choice. He's not a true consumer. He's a fake consumer.
Fake consumer.
Okay.
Choice.
He's a fake consumer. He's a fake consumer in the sense that he has no choice. He has no sovereignty to choose treatment. Number one. Number two, he is, don't take it otherwise, I'm also a doctor. I'm a public health specialist and I'm a radiologist. Another is that you are making him fool at the cost he is paying. You see?
Yes.
He is paying for the ultrasound, he is paying for the drug, and he has no choice. It's no go. Therefore, the issue of ethics has got higher value. Because the doctors are thinking or behaving or treating on behalf of patient, thinking that they are thinking all the best for them. As if like a mother cannot think of something going bad to her kid. The same way, the doctors should be so ethical that it should be always in favor of patient. So therefore, it's quite critical to say exactly the consumer right straightforward as it applies with the buying a biscuit or a jacket or a sari. It's not like that. Okay, so we should be a little bit critical in this issue. Who is the real consumer in health services? That's, I think many people agree with this. If not, we can continue the discussion. So now, we go to some cases. I like to read it aloud, and I also like you to read that if possible. So here are some cases which are quite confusing and difficult to decide as such. So this will lead us to come to a conclusion, what is right, what is wrong, what we should do, what we should not. That's the question we'll answer later. Because ethics is a moral law. But this moral law is not followed by everyone. Therefore, we put this in the law. Either it is in the professional conduct. For example, we have got professional ethics in medical council. As a being member, executive member of the medical council, if any doctor is not following that ethics, we'll scrap his certificate or the license. It means that ethics is incorporated into the law, assuming that they follow this, even if they don't like. That's one. Another is ethics is related to philosophy, your culture, your modern practices, equipments, so many choices. So we need to have really a good balance on them. So there is not a single answer for that. And after reading few problems, I think we will realize that. Let's see this. A woman enters the emergency room with stomach pain. She undergoes a CT scan and is diagnosed with abdominal aortic aneurysm. We know that. It means the part of the aorta is weakened and ballooned, and it can rupture any time. And if it ruptures, then the death is sure. Okay? Maybe doctors, they realize it. And the cause is it's straight and bulge. The physician informed her that the only way to fix the problem is surgically, and that the chance of survival is 50-50. They also inform her that the time is of essence, and that should the aneurysm burst, she would be dead in few short minutes. The woman is an erotic dancer. She worries that the surgery will leave a scar that will negatively affect her work. Therefore, she refuses any surgical treatment. Even after much pressuring from the physician, she adamantly refuses surgery. Feeling that the woman is not in her correct state of mind and knowing that time is of essence, the surgeons decide to perform the procedure without consent. They anesthetize her and surgically repair the aneurysm. She survives and sues the hospital for millions of dollars. You see? So because the patient idea was she is erotic dancer and she cannot continue her profession because there is scar on the chest. Okay? So she refused it, but the doctors think she is giving life or compromising with life for a dance or for a profession. So I think she is not deciding correctly. So the doctors forcefully, let's say, they operated on her and she survived. And there is a case, it's a court case. So now we have a few questions. The questions are, do you believe that the physician's action can be justified in any way? Number two, is there anything else that they could have done? Or is it even right to take away someone's autonomy? Because in ethics we are talking about that autonomy. Would a court order make the physician's decision ethical? And what would you do if you were one of the health care workers? So these are the few questions from this scenario. Maybe we can continue later, but I would like to ask some of the students who can come up and maybe give their logic. Is it okay, or we just go through the questions? Okay, we go through the questions, okay? This is one. Number two. Okay. This is about a mother coming with his son, in which there is a special treatment called cow, in which they have got something put fire into a small ball and then put on the skin so that it sucks the bad blood, bad blood, and the remaining blood is the pure blood. But when the physician examines, the child winches, right? So the question is this a case, like we're talking about the indigenous practice also, is this a case of human right violation or child abuse? Because it's giving pain to the child. Okay? So this is the summary of that one. So you used to raise the bad blood and to improve, and you debate whether or not you should call a child protective service and report the mother. Okay? So in this case, in indigenous practices, there are lots of things which are going on in which there is a conflict. For a medical practitioner, we may call this not very scientific, or in a bad word, it's a nonsense, something like that. But for them, it's a practice from generations, okay? And there is a strong belief that it's going to cure the child's problem, like in terms of bad blood or good blood? Maybe our professor would like to answer later. Anyway. So now the questions are, should we comply or ignore this treatment as useless, or could there be something gained from it? As one, what lesson we learn that people are practicing, which we do not believe, let's say. Okay? Number two, when should a physician step in to stop a cultural practice? If someone answers when it harms the child, remind that the person that there is some pain in many of our medical procedures, for example, giving injection. If you are just talking about there is infliction of the pain by the mother, by her ignorance or something like that, then what about the pain we are generating, giving injections or putting catheters, something like that? So how we compare? Number three, should the physician be concerned about the alienating the mother and other people of our ethnicity from the modern medicine? Means, okay, you believe in our system, okay, don't come to us. There are some doctors saying that, if you don't follow me, don't come to me, something like that. Is it like that? Or do you think the physician should report a court case to form authority, the mother? Okay? So, when we call it's abuse, and when we call or accept as indigenous treatment. Right? So this is number two. Okay? So I just go through questions and then in lunchtime we can have discussion. A man was severely by an accidental petroleum explosion. Gas shouted. The physician forced him to the treatment because he was disabled. And you can imagine the injury after explosion of the petroleum station. Though he survived the treatment, he still argues that he would have been allowed to refuse it so that he could die. You see, he was saying that the doctors, they saved me, but it's the same on them. They should not save me at this stage because I'm now on the street. It's better to die than having this life. So now the question is, one of the physicians say that born patients are incompetent to make decisions when they first enter the hospital because they are in such a great deal of pain. However, patients like him can be a great deal of pain for a very long time. In such cases, what should be done to determine competence and when should this be done? Because in ethics, in bioethics or medical ethics, the doctors have a liberty to take their autonomy. Right? And this is one of the conditions. If you blame them or he is not competent, okay, we decide for them. Okay? Do you think the fact that the patient could not see a future for himself should have been taken into account when determining his competency? Could this have clouded his judgment? He thought that he would end up the street corner selling pencils. Okay? So he's blaming the doctor. And do you think that the fact that the patient was going to recover and had the possibility of living a happy life and if not treated would end up suicide or murder? What if he did not have this possibility? Means the possibility is that by making him survive, we are putting him in another danger that in frustration he may end up his life. Okay? And after his recovery, the patient attempted suicide. Should the physician have let him die? Is it ever correct for a doctor to allow a patient to kill himself? So it's a question of euthanasia. That's also now becoming a big ethical issue. And do you ever think that it is correct for a physician to break a competent patient's autonomy? If so, is this one of those cases? Patient is in pain and he said, don't treat me, but doctor says, no, you need treatment. He survived and this is the situation. So what do we do? Next, a woman was diagnosed with motor neuron disease, we know that, and is the Stephen Hawking's case, like disease like that. And this condition that destroys motor nerves and making control of movement impossible while the mind is virtually unaffected. People with Motor neuron disease normally die within 4 years of diagnosis from the suffocation due to inability of the inspiratory muscle to contract. The woman's condition has steadily declined. She is not expected to live through the month and is worried about the pain that she will face in her final hours. She asked her doctor to give her dimorphine, is equivalent to heroin or morphine or packaging, something like that, for pain. If she begins to suffocate or choke, this will lessen her pain, but it will also hasten her death because it causes respiratory depression. About a week later, she falls very ill and is having trouble breathing. So now, does she have the right to take this choice, especially in view of the fact she will be dead in short while, or let's say 6 hours? Is this short amount of time she has lived ethically relevant? And is there an ethical difference between her dying in 6 hours and dying in a week? Because that morphine is hastening, quickening the death. So is it any difference that she is dying in 1 week or in 6 hours? Is this right for a patient self-determination power enough to create obligations on the part of others to aid her so that she can exercise her rights? She clearly cannot kill herself. She cannot move, but should someone be forced to help her or to find someone to help her? Means there are many doctors, like some are doing this, some are not doing this. For example, determination of sex. Some radiologists, they say, I don't practice this. Some say, okay, I do secretly, like that. Yes. So should we send this patient to someone who can practice this to hasten the death? Should the money used to care for this woman be taken into account when she is being helped? Do you think that legalizing euthanasia could create conflicts of interest for the patient or the doctor? Will people feel that they need to end their lives earlier to save money? Because there is a debate that there are Scandinavian countries, they have legalized euthanasia, and in the US also now more than 12 or 15 states they legalize, rest of them they do not. In Nepal also there is no legalized euthanasia and like that, so this is a question that whether she can decide this or not. And if you were a physician, what would you do? If you would pass her off to another doctor knowing she would do it, does this free you from your ethical obligations? Okay, this is another one, and now we are coming to end. Adhikari, this is one more. Means we have 6 cases. Another case, a woman after a bout with uterine cancer had hysterectomy, surgical removal of the uterus. Before its removal, however, she had several eggs removed for possible fertilization in future. Because it's a high-tech we can do now. Now married, the woman wishes to have a child with her husband. Obviously, she cannot bear the child herself, so the couple utilized a company to find surrogate mother for them. The husband's sperm is used to fertilize one of the wife's eggs and is implanted in surrogate mother. The couple pays all of the woman's pregnancy-related expenses and extra $18,000 as compensation for her surrogacy. After all expenses are taken into account, the couple pays the woman approximately $31,000 and the agency approximately $5,000. Though the surrogate passes stringent, rigorous mental testing to enhance she was competent to carry another couple's child, after carrying the pregnancy to term, the surrogate says that she has become too attached to her child to give it up to the couple. A legal battle ensues. Now, okay, so in United States and in many other countries, it is illegal to pay a person for non-replenishable. It means, like, you cannot take kidney because kidney is not regenerating, but you can take blood because it is regenerating. So if it is so, then people would be buying all the organs from the poor people, let's say. So therefore it is not allowed, it's illegal. The fear is that money will influence the poor to harm their bodies for the benefit of the rich. Do you see a parallel match between this case and that law? It is equivalent or not? Can allowing surrogate mother to be paid for their trouble allow poor women to be oppressed? Because it's a big issue in India. It was an issue in Nepal also. Now we have completely stopped surrogacy. Otherwise, all the embassy people were using Indian women coming to Nepal, giving birth and get one certificate, birth certificate, and go back home. It was now stopped.
Yeah.
And it was in Thailand, then came to India, to Nepal. So now I think these people are finding some good place, like maybe in Africa or like that. Does paying the surrogate harm her and of the child dignity? Is it selfish for the couple to want children of their own genetic makeup? If yes, does this change if you can easily have a child? Because there are hundreds of children on the street. Why don't they pick up one if they are so generous of the children, so of the child? One of the main arguments against the use of surrogate mother is that carrying and giving birth to a child is such an emotional event that is impossible to determine if the surrogate will be able to give up the child. Though adults enter into contract, the child could ultimately suffer if a long custody battle ensues, means there is a mental effect on child. With the possibility of such battle, do you think it is acceptable for parents to use surrogate mother? Okay, so we talk ethical issues on surrogacy. Do you think that if the surrogate is awarded the baby, this could cause emotional harm to the child? Who do you think should receive the child and why? Okay, this is also a question for students. 6. This is the last one. Sorry to take your time. A married couple wishes to have a child. However, the 32-year-old mother knows that she is a carrier of Huntington's disease. And this is autosomal dominant. It is the chance of having disease is 50%. So then its symptoms begin with slow loss of muscle control and end in loss of speech, large muscle spasm, disorientation and emotional outbursts. After 15 to 20 years of symptom, Huntington's disease ends in death. SD is a dominant, like I already told, it is a 50% chance to pass on. Feeling that risking the baby's health would be irresponsible, the couple decide to use in vitro fertilization. The fertilization of several eggs in the laboratory, and eggs are harvested and using the special technology which is disease-free. I think we know that. Okay, we can have in vitro fertilization and we can also check the genetic makeup. And they want to make sure that there is no disease. So the physician then fertilizes the single egg and transfers to the embryo to the mother. Approximately 9 months later, the couple gives birth to a boy who does not carry the gene for the disorder. Means a successful case. So now the question is this a case of eugenics or not? First, it is defined as the hereditary improvement. Let's say like the Hitler way, just selecting certain race or certain characters. Would it be acceptable for the parents to select for sex as well? Or should they only select an embryo that does not have SD? Means the question is now we have banned selection of the sex. Okay, whether it's male or female, it's illegal in most of the countries, almost all. So if that is illegal, is this legal? So is the only sex of the child be illegal and rest of the disease selection is legal? Or what? Is it ethical for this couple to have a baby when the mother would begin showing signs of Huntington's disease when the baby is just a few years old? Because mother is going to die. Okay, so does she have right to leave an orphan child knowingly? Is it ethical on the couple part? And with this technology possible, would it be ethical for this couple to have a child without genetically ensuing it would not have the disease? What if we did not have this technology? Would it be ethical for a known carrier to have a child? If not, how far should this carry? A carrier of cystic fibrosis, which is a recessive disease, which has got 25% of chance of getting disease. Weighing everything we have discussed, do you believe the couple acted ethically? Okay, so there are questions. So this is the end of the question. So there are, we have seen lots of clinical cases in which a large debate is possible, and I am sure there is not a single answer. If there was a single answer, then I would not present this here. Okay, so based on this, our next session would be, especially for the student, how to come to a conclusion. How to come to a conclusion in clinical case. So what are the principles? What are the basis? And what would you do if you are in difficulty? So because now I tell you another ethical problem, that if a 14-year-old girl coming to me for abortion and ask me to keep it secret because confidentiality in question, should I inform the mother or not? Number one, is a 14 years means she is a minor, right? Number two, she is pregnant, which is a big event as such. Okay, so is it ethical to inform her mother, or it is unethical, or just to refuse, or to accept her to continue pregnancy? Okay, so these questions are there. Same continues with the. For us, especially, we have problem in hospital, because I'm a chairman of one of the community hospitals also. We run 100-bed hospital with all the specialty. So now, how long we keep a patient in ventilator? Because there are lots of patients waiting for ventilator. Or, later we'll be discussing that there is one third stage lymphoma boy of 20 years age, and 8 years old pneumonia patient to whom to admit. You see? So lots of queries are there. So in afternoon session, let's say after lunch session, we will be trying to answer these questions in a logical way. Okay? Because you cannot just throw the questions and keep quiet. You should come to a conclusion. Okay? As a student, as a physician, so we need to do something. We cannot just say, oh, this is problem, that is problem. So my presentation would be straightforward, okay, based on the principles. So what are those principles, we'll talk a little bit later, and we'll teach students the way how to, dig out the problem and come to a conclusion. Thank you very much.
Thank you very much. I'm just teaching at the college in Japan, and I think personally, because we don't have enough time, I just want to provide my opinion on issue of surrogate mother. I think it's a really big issue, and then that's why when physicians and the people in the medical sector are paying attention to, I think it really causes more complex problems, motivated by larger audiences and by those who have money and power. I feel like that's all behind, this problem. That's behind all this problem. I was alerted about this incident by a Japanese man in Thailand. He was found to have several 10 to 12 surrogate mothers in Thailand. And then the motivation behind it was to basically he comes from he's a son of the biggest conglomerate of the Japanese company. So the motivation behind was to have Thai national. So if he has a child who has a Thai nationality, then he can transfer the businesses from Japan to Thailand in order to expand the business in Thailand. And later he was found to have multiple surrogate mothers in Myanmar and other ASEAN nations. So what all this tells me is that it's really tied to this money profit-making scheme initiated and motivated by the globalization. I think globalization is a wonderful thing, but there's always those who have power and money, and then it really fits into their interests. So it is an ethical issue because you play with other people's lives. But I feel this is very complex and difficult problem because it's tied to the power, status, money issues. So that's not something we can easily solve. Does law catch on before anything like this will continue to happen? Other hideous, just disgusting cases like this.
Sure.
Just
Sure. So that's what we throw these questions to audience, and we ask students to examine different aspects of surrogacy and try to find out some principal ways so that you can argue on something, because you can argue on both ways. And as you said, there are some logics which you think is quite nonsense also, because you just have money and you just play with what you like. Is it ethical or not? So let's debate later, no problem. It's okay.
Yes, so actually, in the last 2 weeks, the judge in Thailand has granted him custody of the children because basically it was the best interest of the children. It's better to be looked after with enough resources than stuck in an orphanage in Thailand. So we're moving to Japan. But I'm not sure the cases
This is the case,
in Myanmar or other countries what will happen. But the best interest of the children is most important here. Now they're born, what can they do? Hopefully they're loved by him and his family. Okay, thank you very much. So we'll proceed for lunch and come back after. Thank you very much. Thank you. Excellent presentation.
Kind of a context issue. One of them is the issue of information, because you find that from the way all these scenarios are talking about and what you're saying just now, that's why I didn't ask you a question. I think there is a gap of information between those who are doing the abortions and those who come for abortions, whether they're from within Nepal or from outside Nepal. That is one thing. There is a question there, the consumers or the patients or those who seek for such services, they are not well informed of the legal and cultural. It's a packet of all those things. This is one. The second thing here is the question of, let me give you an example in South Africa, in Southern Africa, especially with regard to certain aspects. You see, because of the colonial history of Africa, whereby borders were just demarcated in the Berlin Conference 1885 there, where they just chopped. You find one ethnic group this side, the other ethnic group this side. The Sanya in Botswana, in South Africa, in Namibia, they all. So when, for instance, there is the issue of intellectual property rights on a particular traditional medicinal plant like the hoodia, which has been taken by multinational corporations because of slimming, things like that. So there are certain legal frameworks covering the countries of Southern Africa because people are across different places. Do you have such things in South Asia?
Yeah, especially in terms of treatment, Thailand and India, they are the hub for medical tourism as well, for the better treatment, let's say. And in some cases, Nepal is very popular for treatment of eyes. So in the southern belt, almost 90% patients are from India, because the care is free or either very cheap and very effective. So there are cross-border issues also, but we are following law of the land. It's the law of the land. Maybe you can say a patient coming from India can have abortion in Nepal, that's it.
And then only going to
Yeah, because we follow the law of the land.
which land?
That's it. So because they are Nepal, law of the land, because their treatment is here. So that's
you allow abortion.
Yes.
But your law is for then Nepalese citizenship, na, sir? Your law is for Nepalese citizen. If a foreigner come here.
Yeah.
Yes, that's a question, but in practice, you see, in practice, we do not discriminate where are you from. So if you say like that, we should not treat any Indian for eye, you know, or any other like that.
That's a bit problematic.
Yeah, so that's what. So it's like the treatment of the patient goes according to the law from where they are practicing, because it is the ethical issue for the practitioner, and what they are practicing according to their law. So that's the issue. So I think especially for treatment, they do not usually, the doctors, they are not discriminating from where you are. Especially if I go to India, they don't think I'm a Nepali and they don't treat me. They treat according to the law in India. It's so simple and fine. Let's make it simple, and make it practical also. That's why.
Can I ask a question?
Sure, maybe what I suggest is
Yeah.
you start your presentation,
Okay.
and then I have more questions as we go through.
We respect our
Sorry.
audience. No, it's okay. It's okay. The debate can go longer and longer. So, these are the some of the questions we already know each. Why do people have as they do despite of available medical facilities, as you are asking that, yeah, these social things, and why different people react medical problem in a different way. Some go for home treatment or let's say herbal treatment, some go to hospital, some wait for 5 days at home so that they get more sick, so that it is presentable to the hospital. And why some people are more vulnerable to certain conditions compared to others, and so many questions are. So therefore, we need to have medical knowledge and social knowledge to answer these questions. That's, I think, is already addressed. So therefore, we are linking this ethics to this public health, to environment, to pharmacy, the culture, and everything. Okay, so everything is linked. And before we start, if you say ethics, ethics is a moral law by origin. It's a moral law. But all people are not moral.
Yes.
For example, I know I should not do sex determination. I'm a radiologist also. I know I should not do sex determination for a pregnant lady, but in the greed of money I may do secretly, you see. So that's how it is linked. So this ethical issue is linked to professional behaviors and incorporated into law. But by definition, it should not be incorporated into law. Everybody should understand that I should do this, I should not do that. Okay? It is all defined by your culture, like given from family and all, but we are not doing. And one of the examples, so it is ethical. So our practice should be ethical. So what is not ethical? One example, just to discriminate for students. Sociology is non-ethical. Anthropology is non-ethical. You know why we say non-ethical? Means, if you do some study or research in sociological aspect, we just describe it. We don't say this is right and this is wrong. For example, in Nepal, in my caste, if a woman is having periods, she is not allowed to enter into the kitchen. She is untouchable for 4 days. You see? But my neighbor, who is a neighbor, they don't believe so. These women are like as normal. You see? They consider this as a physiological process. So in sociology, you see, in sociology we never say to bar from kitchen is ethical or non-ethical, or not to bar from is ethical or non-ethical. So that's why sociology is non-ethical. But medicine is ethical. Because there are demarcations. There are boundaries. Okay? Some are tight boundaries, some are loose boundaries. Some are decided by family, some by profession, some by your science and all that. Is it ethical for a modern medicine doctor to prescribe Leaf 52? I think you know what is Leaf 52. It's an Ayurveda drug. Is it ethical for a doctor to write Leaf 52 who is practicing modern medicine? Is it? But people are doing. Right? Is it ethical for an Ayurveda doctor to prescribe antibiotic or not? But they are doing. See? So, for this medicine, like traditional medicine also, they are prescribing lots of mix-up, okay? Which they are not expected to do. So that's what we learn. So, there are lots of philosophies on it. So let us go through this small story. Maybe many of you have known it, but if you know, that's all right. If you don't know, that's also all right. There's no problem. Something interesting. A big company was hiring new staff. The question of the written exam is, you are driving a car on one big storm night and you are passing a station nearby. And there are 3 people who are waiting for the bus. One old lady who is dying, means very old, sick, need help. One doctor who saved your life before. And one guy, lady, who is someone you have been dreaming to get married to. 3 people waiting there in a difficult night. Then you can only take one patient. That means let's assume that is a sports car. So which one you will choose? Please explain your reason. Okay, so this is the question. So now I'm not going to ask you this question. I will just go through it. I don't want to waste time. We do not have time. So I'm not sure whether it is some kind of personality test, and every answer has its reason. Number 1, the old lady is going to die and you should save her first. However, old people always end up dying anyway, means both ways. Okay? You can think that way. The other, we should take the doctor because the doctor saved my life before and it is the perfect chance to pay him back. At the same time, some people believe that you can always pay the doctor back in future also, not now. Okay, both ways. But you may never be able to find a perfect lover once you pass the chance. You see? So maybe keep in your mind. Okay. Anyone you can choose. And the meaning is that you may have some justification for each. It doesn't matter. Therefore, for my problems are like this. I'm not stick to any answer, but we should have some principle to answer. That's it. That's the point of this presentation. So now, within the 200 candidates, the one who has been hired did not explain this answer. He only simply stated that, give the car key to the doctor, let the doctor take old lady to the hospital, and I stay to wait for the bus with the lady of my dream. You see? So this could be a best answer, so that everybody's problem is solved. But the problem within us is, we do not want to give to others what we have. That means we do not want to give our car key to others. And the moral is, giving something we have can solve a lot of problems. So therefore, especially in medical practice, there are lots of things to give to the patient. And we should learn that. And we should train our students that way. Therefore, in medical school, where I teach, I tell them, my dear, if you do not want to wake up in the midnight while you are in bed with your partner, please don't be a doctor. Because the profession demands it. And you have chosen it. And then you must differentiate what is occupation and what is profession. Occupation is what you eat. Maybe you eat by opening up a shop or doing painting, okay? Anything you eat. Or maybe you are renting your house to eat, to survive. Maybe your occupation. But profession is that part of the job that has some disciplines, that has some boundaries, that has some restrictions, and there is no liberty under this. So therefore a doctor on duty cannot say, I'm sleeping. That's the difference. Okay? So on ethical point of view. So there must be certain duties and rights. Okay? And these duties are bounded by your profession. Okay? So we try to convert ourselves to be professional. Right? Okay. So there are so many disciplines, there are conducts also, so all our learned people, you can share my PowerPoint free of cost, no problem. Yeah. So you can take it. So I do not want to read it out all. So ethical conduct, simply doing the right things, but in reality it means more. It involves acting the right spirit out of an abiding respect and concern for one's fellow creatures. Okay? So the area is broadened. Okay? The horizon is widened in ethics, or you can say the ethical conduct. If everybody was ethical, mind it, if everybody was ethical, there would be no need of police, no need of law, no need of army, no need of border. But we are not ethical, to be honest. Okay? We are centered to ourselves. So let us try to give something out of it which the profession demands, not more than that. Only that much which profession demands. So historically, if we say in medicine, it is from the Hippocratic Oath, in which he taught us to consider your colleague as brother and sister, not to do abortions. Okay, so always be ready to treat for patient. Okay, do not take any fee out of them. Something. Okay, so it started from there, and there are Christian teachings also, Hindu teachings also, different mythologies, cultures, and philosophies are there. They all are teaching us morals. Okay, to be ethical. Okay, like not to pee on the road, not to thieve pencils of a friend from a friend, like that. It's all taught in day-to-day life also. Okay, so these all philosophies are there. Okay, it started in the UK also. While prescribing drugs, they wanted them to be certified by some authorities, okay, and have some license. It started from there in UK 1815. And then there are American Medical Association in 1847 was established. They also produced or developed a code of conduct in medicine. And there are Nuremberg Code. Here is a quite sad story. What they did was that this code was developed out of very cruel or inhumane. I'm not going to read all these 10 points, okay? Because at the time when there was invention of penicillin, to make it short, okay, penicillin is still, in some cases, drug of choice for syphilis. Nowadays it is resistant, but the penicillin for a long time it is the drug of choice, and syphilis is a treatable sexually transmitted disease. Okay? But what these people did, those blacks were in prison, they did not give any penicillin to see the effect of the disease, or in technical term, to observe the natural history of the disease. You see? So cruel. Okay? The drug was available. Since they were prisoners, they were not given antibiotics. Okay? So many people died in agony. So after that, this code was made for that, and we heard that this is the case of 1932 to 72. I thought one of the researchers at that time, after this code, he hanged himself by regretting what he did. So in the history of this ethical development or history of ethics, This is a landmark we consider. And the Balmont report came and set 3 ethical principles. Now we call 4, I'm coming later. One is the respect for the person, another is beneficence, another is the justice. It means the person or subject should be treated as an autonomous individual. Okay? They have got all the right to choose treatment or not to choose treatment. So please try to relate my story also. Okay, so these are the answers also, what we are talking about. The answers, if you remember some of the stories we already told about. So autonomy is the right. So there must be a choice to the patient and they can withdraw the treatment or research in between. Another is beneficence, always think for the benefit of the recipient. Number 2, and justice. This justice means equal treatment. For example, in our practice, what is there, especially in the government hospital, if there are people in queue, who are in queue, those are who are from villages. Those people like me, if they come, they go straight to the doctor and say, "Hi doctor, how are you?" Then get the treatment and go. Right? So that's not the justice. Okay? They should also be in queue, and we may talk later about the equity and equality later. Okay? So that's also a debatable issue. Then we can come to, there are some common rules there. So therefore, to make it common, equal to all, we have got Nepal Health Research Council in Nepal, and under that, each institute has got institutional review committee. We don't say board, but most of the country they follow the same rule for the ethical conduct. And similarly, World Medical Association also developed this Geneva Declaration. We appreciate it, and which reach and educate graduating doctors. Nowadays there is no system of getting oath access, but while you are going to register into the medical council, they give you a paper sheet and you should give a thumbprint and the signature that you agree these things. And these are some points may be adjusted according to the country law, but most of the countries they accept it. Okay, so there are 10 points. So it's all, let's summarize it, all good points. All good points. Okay, no bad points are there. Okay, and my life service to the humanity, I give my teachers respect, this, that, so many. Okay, so I'm escaping it. Is it too fast? I think the reading out is also boring, no? Because you can read later. And UNESCO Declaration on Universal Norms on Bioethics came in 2005. And they have got 2 broad streams they give. One is the derived from the ancient time, okay, the practice. You can name the Hippocratic Oath and all that. That is one, okay, from the medical profession, what to do and what not to do. And in recent times, there are international human rights law. So this report is primarily based on the protection of human genome and protection of human rights and right for treatment, equal opportunity and all that. Okay? So now what we are doing is that we are still collating it together, okay, to follow your historical background and practices, plus newer advances and newer, values developed. Okay, so now we concern more on the right of the individual. You can say people also, you can say individual also. The individual right is at first. So the patient, they have got sovereignty, they have got choices. So in this context, we talk about this euthanasia. A woman, let's say, a woman is pregnant, she is in village, and she is not willing to come to hospital, let's say. We know coming to hospital is more beneficial, but if she says, no, I don't want your care, so what should be our role? Because in one way, she is putting herself in danger, maybe because of socio-economic conditions or beliefs like that. The other way, she is putting herself in danger, that we know. Okay. Okay, so this bioethics term came quite later. These two gentlemen are there to put this on. One is in the comprehensive way, and another put this term in an institutional or institutionalize the terms as such. So now, if you see the definition of bioethics, it's so long, you see, means including like biosphere and the accessibility, scientific and technological development. So looking at the aspect of bioethics, it has become so complicated that whether we are ethical to have lunch at 1 o'clock or not, okay, or we are ethical to have whole day seminar like this, having yawning and busy with our mobile and Facebook, you see. So it means like its horizon is much wider. Okay? And what we are trying is we are trying to put it everywhere, and that may be the reason we may not be very successful. Okay. So its scope is also two levels. One is at the individual, community, or group level, and another is to the level of decision makers, like professional groups, public, private institutions, corporations, and all that. So it means it is covering not only the individuals, but as a nation and international communities as well. Right. So difficult ethical problem, if you say, now we are in difficult position and cannot answer straightforward because of these things. Human cloning, you know cloning, right? We can produce copy of it. But human cloning is so useful that we can produce monoclonal antibodies, which are the treatment for certain disease and certain cancers. You see? But we are not at the same time allowing you to cloning for humans. We are restricting it. You see? We have technology. So if you can allow one, why not others? And we have got predictive genetic testing is there. Now we can diagnose the Philadelphia chromosome in the uterus before birth, okay, which is producing leukemia, or in general sense is called blood cancer. Eugenics, new reproductive technologies like in vitro fertilization, antenatal screening, abortion, priority setting, underserved population, brain death, organ transplant, end of life issues, assisted suicide. So many things are there. Okay, because of technological advancement, the ethical issues are becoming more and more complex to decide. Okay, so right. So I'm escaping this. So there are some theories in ethics. One is the virtue ethics. It is a quality practice. It says, are my intentions? So it is asking questions on yourself. Okay? Am I right? Am I okay doing this?
Yes, sir.
Yeah. No. People should ask themselves, one, and is the action I propose to take one which would be considered appropriate by a good doctor or by a prudent person? Means, like sometimes we may substitute that if my ideal teacher, let's say, or people to whom you entrust, so you can ask the question that, okay, is a good doctor doing this? So this is one way. Okay? So this is the principle. One theory you can use. Means, what is the good conduct? Number one. Another is deontological. It's a moral theory, which is the duty-based. Is regardless of consequences, we are coming to consequence. Regardless of consequence, we just think which is right and which is wrong. Okay? According to the principle. So, is ever right or always wrong to kill? to tell lie or to break a promise. For example, breaking news. For example, one patient is coming to us with, let's say, chronic illness, and we ask them to do HIV test, and the test is positive. Okay? According to this, you should tell. Okay? According to this. But number one, what he said, if there was a good doctor, he will find a good time to tell, looking at the psychological condition of the patient. Okay? So this is more straightforward. So deontological is a duty consideration, includes the right as well as duty and omission as well as act. So it's according to the established moral principle, we do it. Okay? Regardless or not considering the consequences. Another is consequentialism. So now here what we do, we see the consequence of proposed action. Okay? To a young lady, 13 years old, unmarried, okay, to do abortion or not, you may think of consequence. If you do not do, what happens to her, and if you do, what happens, something like that. Okay? So here, there are likely to be good or bad in short term and long term for the patient, doctor, family, and society. What will promote to net balance for good or harm to the individual as well as the greatest good for the greatest number. So here we also like to set up some moral also for the society, okay, consequences. For a young lady who are pregnant, unmarried, young age, maybe if you keep on doing abortion, maybe you are encouraging other girls to come to you, maybe that is one way of consequences. The other is like you are stopping or like you are cheating or saving or ruining of the life of that girl. She is so young and have to study or to do some, like what say, for her bright future. Okay? So this is the consequentialism. Another is the right theory or the privileges. So whether it is the natural arise from the human being or legal and therefore enforceable, positive rights impose a duty on others to act, whilst negative rights prohibited by others. So it means this right theory or privileges have got, people have got right. For example, this theory, if you don't mind, like in Bangladesh, circumcision is always emergency. Always emergency. Isn't it? They do not have to be in queue. Okay? This is set. You see? And like the privileges are given to freedom fighters. Okay? Freedom fighters. Jobs. In our country also, privileges are given to disabled or let's say victim of earthquake, all that. Okay? Privilege one. And another is the descriptive or narrative. This is the approach that are morally embedded in the stories shared between patient and clinician and allows for multiple perspective. So here there are more, you can say the consensus, okay? Agreement between service taker or service seeker and the service provider. Okay. And primarily there are four principles we have to follow. One is the respect for the autonomy. Here is even confidentiality or breaking news, so are included here. And beneficence, and it is the always for the best interest to the patient or for the patient. Another is the non-maleficence, means do no harm principle is there. It means, for example, a patient is coming to me and I'm not sure about the treatment, then morally or ethically I should not treat him or her. Because if I treat, I'm not sure the consequence. I may doing harm because I'm not that much sure. But if you do not treat, the patient always have chance to have better treatment. So this is the principle here. Okay? So you cannot do a trial to the patient. Okay, I got a new drug, I can try on you, or you can try. You cannot do this because you may harm the patient. So the principle is do no harm. Okay? And justice, concern the distribution of the resources and decision to who get the what treatment, fairness and quality. And this quality we are also in the name, for example, we are providing tetanus toxoid free of cost to all the women. Does it mean that men, they do not get tetanus? Or should they die of tetanus toxoid? See, we are giving free of cost treatment for tuberculosis or let's say worm infestations, and we give free treatment for under 5 children. And now in Nepal also, if you are more than 70 years old or less than 15 years old, all cardiac treatment is free of cost in Nepal. Does it mean that like the 40 years old should die without treatment? Okay. No. So this is based on the justice, because considering that they are more vulnerable, okay, more likely to be deprived of treatment. Okay. So that was the justice. Okay. In that way, we are trying to treat. We like to treat all people free of cost. No one should die, but to set the priority to make justice on them. Okay. Okay. Yeah, it's a free of cost.
Yes, Bangladesh is not working.
Yeah, it's a free of cost, and for now recently declared but not implemented is that if you have to transplant a kidney, it's free of cost, but you have to find your donor legally. Okay? You cannot buy it. But your family member can donate. That is free of cost. And dialysis is free of cost for your life. Okay, in Nepal. And then you can have, the proposed one is 5,000 rupees per month as stipend for all suffered from cancer, then kidney failure, Alzheimer, Parkinson's. There are a list of drugs, diseases. Okay, so government is giving all that. And as a social security, if you are more than 70 years old, you are getting 2,000 rupees per month lifelong as pension. Okay, so Nepal is quite forward in that, like investment in social service. Okay? So in many countries it is not there, but still the Nepal is trying to help people, poor people, or you can say vulnerable people, and this is part of the justice, and it's more ethical on that way. Okay. So other principles are the respecting the persons and truthfulness and honesty should be there. Then now we talked about last time my colleague also, because I didn't hear much about other presentation, but now we talk too much about the evidence based. Okay? So let us have a small look on it. What is evidence based? Evidence based means anybody? What is evidence? Because nowadays we talk too loud about evidence-based medicine, evidence-based practice, evidence-based this, that. So what is evidence?
Based on research.
Sorry?
Based on research.
Yeah. Based on the findings. Okay,
research.
or research, or like. So primarily it is a statistical tool. Primarily. Because you need the data, you need to analyze, okay, which is right, which is wrong, or borderline and all that. And this statistics is very interesting thing. I also teach biostatistics. So they say, if you start with certainty, you will end up in confusion. And if you start with confusion, you will end up in certainty. Means, how you prove what you want. So there are lots of manipulations in statistics as well. Okay? So lots of biases also, but here the idea is not that. The idea is every occurrence, every happening is evidence. Okay? Every happening, every occurrence is evidence. But this evidence has got label. Okay? So this is labeled in a hierarchical order. So if you go to the last number 4, evidence obtained from expert committee reports or opinion and clinical experiences of respected authorities means I am teaching in a medical school for 15 years, let's say, and I observe the character of students and I may give my opinion as, oh, the students from Bangladesh are much talented. From Nepal, they are average. This is my observation. That is also an evidence. Okay, that's a loose evidence. Stronger than that is obtained from well-designed, non-experimental descriptive studies. We know that. And then from at least one type of quasi-experimental, and then controlled trial and randomized control, and finally is a meta-analysis. So larger the data or larger the inferences or information, better the evidence. Therefore, people who are practicing traditional medicine, they have got as a little opportunity or little skill to prove, to make it evidence-based. For example, if he gives me a herbal tea, 1 cup of tea, doctor, this tea is very good for your health. Then I said, okay, good. Oh, I'm drinking this for 3 years. I'm fine. But I don't know whether it is really working or not. Okay? At the same time, I cannot blame that this is not working. So that's how most of this nutritional product, these cosmetic products, these herbal products, and sometimes I make a joke, don't mind if someone is on that. I say because these herbals are very good because there is no side effect, no?
Yes.
Isn't it? So I say that's good because there is no side effect, because there is no effect.
No effect.
Yes. If there is no effect, then there is no side effect. So it's okay, keep on, continue, right? So anyway, sorry to say this. Okay. So therefore, we should take into consideration, if you believe in science, first you should understand that, okay, whether it is social science or medical science or basic science, pure science. If you believe in science, you believe in evidence. Right? And that evidence is larger the number, larger the effect, then better the result. Okay, so that's how. That's what in medicine, you know, I graduated in 1990. Okay, so many years. So in a medicine, there is a very popular saying: if a doctor is not studying for 5 years after graduation, his 50% knowledge will be outdated. And if not, for 10 years, he is useless. Means we have got that big information, that many changes in the drugs, in the information, in the ideas, you see? So we must believe in that. So we should keep a pace to catch that. One edition old book is all for Chapati. You know Chapati?
Yes.
For new edition of Davidson is coming, then the old edition is for Chapati. Like just you sell, it's just you throw it. You can use it, in medicine at least. So therefore, this evidence base should be considered. So therefore, the gradings are also there. So directly based on level 1, 2, 3, 4, 5 we have graded. So this is also, like, I think better to know for students. So how you come to a conclusion, okay? There must be some basis, primarily statistically proved or evidence based. So now you are also dealing with some of the social aspect. So we have problem in practicing medicine, especially low resource country. Even in developed country, medicine is always scarcity. There is no limit of the service. Even in Scandinavian country, even in US. So where to focus? Prevention versus cure. Because most of the people, what they want cure now. But there are remedies for, like ways for preventing diseases. Okay? So that is one dilemma we have. So that's what the doctors are. Their job is quite glamorous, you know. Glamorous, why? You know, the doctor's job is that, number one, there is biological diversity. For example, there are some doctors also, they understand better. My teacher told me, you know what is the charm of medicine? This is charm, good car, good life, good salary. No, that's not the charm. The charm of medicine is that some people get cataract at the age of 40 years, some get at 50 years, some get at 70 years, So there is no equal treatment. That is the charm of medicine. For example, if two people have got enteric fever, they do not have equal temperature. One may have got culture positive, one may not, because culture positive is only 70%, not 100%. May not be leukopenia, may be leukopenia, isn't it? Do we get all typical fever in enteric fever? No. Do we have all relative bradycardia? No. That is the charm of medicine. Therefore, we like to make it more evidence-based. Okay? So we have that problem. And acute versus chronic care also there. Now the problem of the chronic, like if you see the diabetic retinopathy not treated in time, or cardiomyopathy, or kidney failure due to diabetes. Okay? So there are also a big burden to the whole health system. This is also, we should think in balance. Another is ideal versus possible. Most of the talk in this type of seminar, we talk ideal. Government should do this, do that. It should be like that. You should not do this, that, but we are doing. You see? So what is ideal and what is possible? Okay? It means in terms of resource allocation, okay? So in terms of, let's say, you can talk about the drug resistance. I'm in the council, what we are deciding? Okay, if you are prescribing any drug, your identification should be there with prescription. But is it possible? Because every corner, everywhere, the drug sellers, like shopkeepers are selling it. Is it ideal? No. So, and channels of healthcare provisions are there. So in the community, most of the services are costly, and we are also influenced by the researchers, like the ideas from the developed countries. You see, sometimes they say, oh, primary healthcare should be free to all, and sometimes they use user fees should be there, go BF. It should be, the primary care should not be comprehensive, it should be selective. You see, so we are all facing this, theoretical aspect also. And these developing countries are in a big confusion, we say. Okay. Right, this is, okay, this is, right. I already told that doctors know about termination of pregnancy, but it is debatable to perform termination 30 years old girl who does not want her parent to know, see. So, like, so many are there, I already spoke about. And there are primarily 3 duties of the doctors. So in this, the idea is, there are some professional regulation, there are laws, and a doctor or a professional, they do not have any excuse of not being experienced. You cannot say, I'm not experienced, so I did a mistake. No. Okay? It is considered as professional misconduct. Okay. Right. So, and this part also spoken earlier, this doctor-patient relationship. So there are so many aspects like the language, culture, first language, so many barriers are there. And many times when people are coming to a doctor, it is always, or I don't say always, but it's most of the time, authoritarian. Okay, I'm the doctor. And if some patient argues or asks some question like, how this drug works or what are the side effects, then doctor say, oh, you are a doctor, I am a doctor. I just said and you eat or you follow that. That's like that. No? So many problems are there, but this can be eased. Okay. Then we come to some part of the legally valid consent, and I just want to mention it, not longer. My previous colleague told that the doctors are asking to write some consent before operation especially, but that is not the legal document, mind it. That is just a formality. Signing on the consent does not cover the medical negligence or improper treatment. But many people have got a, false belief that they think, oh, I already signed, oh, you signed, even doctors I have heard saying that, you already signed that, like, I do not blame any health worker for any, outcome. That's not true. Okay? That's not the legal binding. That is just part of the counseling. What I'm going to do on you. That's it. That does not mean you can do any negligence. Or for example, you are doing operation of the appendix and you are not liberated to cut internal iliac artery. Just because in the name you have signed the contract. So these are to be understood. And there are batteries also, like unlawful use of force should not be there. In terms of like examining private parts or body parts or giving injections and all that. Okay, and most of the health workers, they think that it is their right to give injection without asking or something like that. And negligence, they cannot breach their professional duty. And consent also, in the consent also there are 3 ways of getting consent. One is express consent, and it may be verbal or written, and usually through the patient. So this means I already told, a signed consent form is not a legal or professional proof that proper express consent has been obtained. Okay, this is all the formality that you have got to inform the patient. That's it. Another is implied consent. Implied means it is, what is it, within it. For example, you do not need to ask patient every time, like once they are admitted in the hospital, okay? Sometimes you take blood pressure, sometimes you give injection and all that. So every time you do not need to ask. So that is the idea. And another is especially for the explicit, it is for the student. They must introduce themselves that they are not doctors.
Yes.
But in our setting, if you do not pretend as if you are not a doctor, they don't allow you to touch. So therefore, in Western countries, the idea is that first you should pass through the skill lab. Okay, once you are perfect on that, and only then you are allowed to go to hospital. Okay, confidentiality. In confidentiality, I just mentioned it that confidentially means keeping the record secret till or even after death. Confidentiality can be said, or the confidential, only when the colleague or the doctor is involved in the treatment. It should not be a talk of tea break. That's it. Even if they are doctors. Okay, so that is the point of confidentiality. And we also talked about the when the confidentiality can be breached. There are normally 4 conditions. Other conditions can be laid out by the country law. One is the infectious disease, which must be notified, okay, to prevent transmission. Number 2, a court order by the judge, so you must reveal information. Another by the police request, and another is the very popular as a terrorist act. Okay, so there are only 4 conditions in which the confidentiality can be breached. And we also talk about the competence. Competency means they understand information about their condition, number 1, and they remember the information, they are not forgetful. And another is communicate their choice, and they know about treatment and they can choose. So that is the confidence. So in the first case, for that erotic dancer, how the doctor justifying themselves that, oh, she is giving her life, compromising life for 1 star, so she is not competent. Oh, ये तो इनका दिमाग काम नहीं कर रहा है. You see, her mind is not working. So they just hold her and did operation. Okay? So that was the only excuse on doctor side to justify themselves that the aortic aneurysm could be treated forcefully. Okay? But if you don't catch that point, you cannot justify your treatment. Okay? So to both sides, right? Competency, and we have got children, okay, and 16 years, in some countries 18 years, they are considered as not competent legally, and in the psychiatric illness also, because psychiatric patients, they have got a delusion that they are not ill, okay, but they can inflict injury on themselves, so therefore these patients are also taken consideration, and their privacy is taken. Right, so this is the competent refusal. I do not want to read. This is prima facie, means at first look, let's say. Okay, so this says there is no choice. If the patient is competent, he or she has got all the right to choose the treatment or not to choose the treatment or withdraw in between and so on. Okay. Okay, so best interest of the incompetent, and this incompetent like decision taking for others, and finally, no, not very finally, I'm also almost at the end, is quite long. So let's say one patient is smoking and having chronic obstructive pulmonary disease, okay, having lots of sputum and all that. So they are coming, and I tell you the usual South Asian way. You are smoking despite of my advice. So if you want a treatment from me, please stop smoking. Okay. So if you don't stop smoking, don't come to me. I'm not going to treat you. You see? So this is one scenario. So in one, let us see this. So in one way, he is protecting, the doctor is protecting patient's lives or giving advice for the benefit of the patient. So what if he does not stop smoking? Should we treat or continue treating, or we should stop?
Stop.
Stop, because they are not following.
Follow.
Because they are in danger, they are putting themselves into danger, right?
Yes.
If I agree with you, because I do not debate much, you know my idea. If I agree with you, what about the people taking part in boxing? Because there is a chance of head injury. Do you treat them or not? Yes. Now you are coming to the point. Or what about the people taking part in car race where there is a chance of death immediate? What about the people who are working in the high voltage electric line? You see, therefore, you cannot refuse treatment. That is the answer. Never. Even if he smokes or does not smoke, it is your duty to tell. But if he continues treatment, you have no right to stop treatment. That is the idea. If you say so, you should stop treating road traffic accident, people taking part in Kung Fu, Karate, boxing, right? Or because they are knowingly putting themselves into risk. So let them put into risk in smoking also and alcohol also. So what's the problem? If people are putting themselves into... So in the name of sports, you are treating them. But for smoking, why not? Okay, so is it new natural that those who are educated and informed, more emotionally confident and more supported by their social environment, give priority to equal competitors? So our duty is to tell them. Our duty is to educate them. But our duty is not to force them. Our duty is not to stop them from treatment. Is it? Am I right that way?
Yes.
Okay, thank you. So now, telling truth also, you can go through yourself, because telling truth is also, ethical part, but it's not possible all the time. So now we have got ethical dilemma, gap, priority, moral, and resolving conflicts. So I go very quick. There is a gap. For example, the ideal goal is to know, but there are obstacles which you cannot do. For example, a patient is coming to you and you wrote prescription of CT scan, MRI, blah, blah, blah. And he does not have money. So what do you do? You see, so there is a gap. Or a patient needs kidney transplant. Can you give your kidney to him? No, cannot. So this is a gap. So many a times, okay, many a times, there are gaps between providers and receivers. Okay? So this is a block. Okay? This is a block. You cannot have them at all. Okay? So economic, social, belief system and all that, like family planning is not very preferable for the Muslim community. Normally, let's say, okay? And the problem cannot be resolved by the clinical context, but can be resolved through the economic and political commitment. So medicine is a politics in a larger sense. You see? So it's a larger reform should be there. Okay. And priority setting, I already spoke out of it. A 20-year-old advanced lymphoma and 80-year-old pneumonia, to whom to admit if there is only one bed. Until when we continue ventilatory treatment and all that, that's another problem we had. And then we had got moral dilemma also. Like, colostomy means this is cutting of the large intestine and put up a bag here so that stool is coming out of here. So many patients do not like colostomy. They say, rather I die, rather I do not want to clean my seat over here. Okay? So that's also a moral dilemma. Okay? That prolongs life because you have to cut a part of the intestine so you cannot pass a stool. Okay? But you have to use a bag. So some patient may choose, oh, I don't want bag, let me die. That's one situation. The other is, you see, patient may choose one treatment. Okay? I have seen cancer patient, despite my advice, drinking their urine. Somebody told, because it cures cancer, not cancer. What you do? So you advise something, they do something. Okay? So this is called moral dilemma. Because what we learn in principle is that you should respect autonomy. Okay? But there are some choices which cannot be acceptable to you. Then resolving conflicts are also there, because now you can say we have a different department. What we do normally, a kidney patient is coming to us and he has got some small heart problem. Oh, okay, you have got some heart problem, go to the cardiologist within the hospital, second opinion. And there are conflicting treatment. One doctor is giving one treatment, other says the other treatment, you see? So this is the conflict. Okay, so we have got some moral reasoning. The idea is that in such a difficult situation, we have categorized. Normally it is categorized the level of judgment. Okay? Number one is novice, means just entering into the medical practice, that is one way. And advanced beginners, those methods are not effective, and competent professionals, proficient professionals and experts are there. So once the problem is there, then we try to resolve it one by one according to the level of experience, okay, level of consequences and all that. Okay? And so this is the last part of the presentation. Sorry to say that. So one is so in the previous problems, how to solve. So you can, I do not say any answer is wrong or right. But what I tell you is that you should stick to one point. Okay? Some cases you put one principle, and in other cases you put another principle. That is not acceptable. Okay? You should consistent with the principle you follow. Clear? So that is the idea of all this presentation. Because there are different ways of dealing with these things, and there is no single answer, and we can justify this way or that way, or blaming the law, or blaming the seniors, or blaming your religion, or blaming or something. That's up to you. We don't mind. But what you should mind is that you should be consistent with the law or the principle you follow, number one, and you should justify it in the sense that you should do justice to the patient, treating them equally. For example, if you do not treat a patient 80 years old pneumonia in the ventilation for this, you should also not treat the other patient even if it is your father. Okay? So that is the justice. So you should stick into one. So there are some approaches here: the principle, causality, perspective, counter argument, application of rules, and onion peel means one by one. So I feel like people are tired. I know it, although there are some slides, and you can go through it. And this is primarily for the students preparing for exams and all that. And one last part is that we have a big problem with this also. Our leaders, you know what they say? This Ayurveda, very, very good, you know, we should promote. They give good speech on that, you know. But when they are sick, they go to Grandi or they go to Thailand. You see, that's the conflict on them. because they are making people fool, to be honest. If they believe so much in Ayurveda, they should also practice, isn't it? But they are not doing. So that's what for our students, you should understand that what is complementary, what is alternative, and what is integrative. Okay? Nowadays, we give more focus on integrative treatment, that everything is available under one roof up to district level of care. For example, there is Ayurveda also, modern also, homeopathy also. So once the patient comes, they have got all the choices at one roof, so that they do not roam here and there. Because in other system there is no diagnostic method. So respecting their treatment method, what we request is that they at least should exclude the disease. For example, same we do in psychiatric illness. Psychiatric illness may be due to some psychiatric component or maybe organic disease. For example, if you have got neurocystic cirrhosis or a brain tumor, okay, you may develop psychiatric symptoms. But we have to exclude. There is no organic disease. Similarly, in alternative medicine practice also, what we suggest is that first you exclude other thing, the organic component, which is available, readily available diagnostic facility in modern medicine. So once you exclude, then you can continue treatment, okay, so that you do not go to the grave situation. So now our concern is, one is their registration, okay, their registration problem is there, their regulation is the problem, and their safety is problem. For example, they use, like if it is alkaloids, enemas and all that they are using. And you know, in Nepal there are very popular big advertisements like how to make your husband quit alcohol.
Yes.
You see, also bigger, how to increase your sexual potency. So many advertisements are there, but what they put inside is modern medicine. You see, they put Viagra in the name of Ayurvedic medicine. You see, so that's what they are doing, and they are putting this disulfiram, you know, disulfiram in the name of like quitting alcohol, secretly. You see, it's separate packet. They are not using their indigenous medicine, so that's the problem there. Okay, and there are lots of bhasmas and churnas. Okay, so there are the ashes of silver, ashes of gold, which are carcinogenic, proven. Okay, they are using that. So we are raising question on that, and we are also asking about the evidence. Okay, evidence, and so even like what is it? They call it what is it? Piles without operation, a comfort treatment. Hydrocele without operation. You see, so lots of advertisement are there without evidence. So they are poorly regulated, because even if someone is opening a local shop like a herbal shop, we don't bother. Oh, it's okay, no problem. Okay? But they are selling drugs. You see, that's one. And integrated healthcare common in many parts, including Western world. So problems are conflicting advice and value judgment, poor assessment, communication between practitioner and even holistically is ridiculous. So that's all. Thank you very much.